Thanks, Jesse, for having me, and thanks for asking me to come and be a part of this great event. It's always something to stay local and offer your insights and try to help people understand and appreciate that maybe we should be thinking a little bit outside the box. So the talk today is going to be a little bit different than we've been hearing all along, and trying to get us to at least think maybe we should not be utilizing our common ways of treating our patients as we have been doing for so many years. I know that when I was in active practice, I did my very best to try to figure out that, I would want to try to find this holy grail. This was shown to me many, many years ago, and I've always been in search of it. And hopefully, we're going to get closer and closer if we can get ourselves away from the use of opioids like we've been so embedded to understand and appreciate, and trying to figure out maybe there are some alternatives. And the alternatives, would be not to be so codependent. I know that each and every one of us has always strived to help our patients not be so in need, let's say, of using opioids, but a lot of times we just get caught up in the industry's minutia with the adjuncts that are also enticing, such as doing urine tox screens, doing genetic testing, and doing other forms of financial incentives that help to complement why you're even using the opioids in the first place. We've heard a lot about pain and the levels of pain and VAS scores throughout the entire weekend, and we try to stay away from that in our office. We always try to ask about functionality and trying to ask about activity levels and whether you could do something or couldn't do something in order to be able to figure out things. I speak on a couple panels. I help a couple of companies, Vertos Medical and Abbott and Saluda, which is an up-and-coming company, and I have nothing here to disclose other than that. I present this slide because, it's one of these things that hits me in the face each and every day, and now that Ken brought it to our attention again that Neil Armstrong was on the moon yesterday, 50 years ago, it's pretty impressive. But, when Apollo 13 didn't make it because of their issue, Houston, we have a problem. And we do have a problem with opioids, even though despite all of our efforts and our guidelines and trying to understand things, Sandy was part of this committee who along with many, many others, were very instrumental in helping us to appreciate that maybe we should have these guidelines, maybe we should implement these guidelines, and how many people actually read them. There was part 1 and part 2, and did people actually try to implement them in their practice? And if they did, to what factor did they actually adhere to them? And remember, they're guidelines. They're not laws. They're not rules. You don't have to participate in them. So therefore, it was an element to help us be an eye-opening door, if you would, to be able to figure out, should we be implementing them to the letter or not? We've always tried to even think about, let's come up with some alternatives. We're using cannabis now. We're using SSRIs, TCAs. We're using calcitonin. We're using a lot of things. Are they really working as effective as we'd like them to? We would hope that we can offer our patients this elimination of ball and chain, but so many of our patients come in just asking for medications, and we just continually put them on a revolving door, and we help them to a degree by understanding and appreciating that they're not going to significantly abuse their medicine, but we definitely do keep them on them because they request and because they do help to a certain degree. But maybe we should be looking a little bit beyond that. Even the federal government has come in and stepped in and said, opioids can be used for legitimate use for long-time care. It's up to the practitioner. Boy, that's a big, broad statement, right? It's up to the practitioner to determine whether they should use this or not. And sometimes we are somewhat misguided. The primary care physicians got on board with the CDC guidelines, and then all of a sudden they started prescribing a little bit too much. I know that I have had patients walk in the office with 6 and 7 patches of Duragesic of 100 micrograms each on their body. And you go to examine them and they're like, my goodness, what are all these patches doing here? Well, my primary care doctor gives them to me, and I take them off every other day and put another one on. So they become so tolerant and so dependent on these medications until the point where your primary care doctor doesn't want to help them any longer, and then they send them off to you, and you have to then deal with the aftermath of detox. So all patients with chronic to moderate pain are in need of some kind of therapy, and they're in need of some kind of use of therapy. So, these guidelines have helped us. We've gotten consideration of alternative treatments, bona fide agreements. We've asked these patients to do a risk assessment tool. We've even done urine toxicology screening. And to many individuals, that's been somewhat of a financial incentive and financial disincentive to people. Some people have opened up their own urine labs. They've had their own toxicology screening labs. And all these have been motivating factors. And even to the point of signing an agreement where you and I have entered into a contract, and are we enforcing the contract? Are we not enforcing the contract? Are people really adhering to what the words of the term should be? This is an important and very interesting slide. This is a recent study done in Australia, and the most important factor here is the fourth bullet point, a 68% reduction or elimination of opioid use at 12 months. I don't know how you and everyone else practices, but in our office, we tried not to administer or allow people to be on opioids if they use alternative therapies. So if you had a spinal cord stimulator, we asked you to come off your medication in order to realistically assess and determine whether the stimulator worked or not. A lot of people use it in conjunction. They think that, the individual has other ailments. They've got knee and shoulder and arm issues, and I put a stimulator in for their lower back. And maybe they do need those medications, but we've come up with a rule, and it's been hard and fast, that we ask these patients to come off of their medications while we have that stimulator in place. The factor of using alternative therapies has now even allowed us to come off additional medications, such as gabapentin. If we can narrow that therapeutic window to make our adjuncts work, such as a stimulator, and it works as effective as it's indicated to do, with people that are not so codependent on these pain medications, maybe we should be asking them to reduce their entire gamut of medicines. And some patients can, and obviously some patients can't. This is an interesting observation of a physician in Norway who is an oncologist. A patient came in with neuropathic pain, and the individual could not stand or could not walk. And he started to administer EGFR, which is a epidermal growth factor receptor. And so the physician thought, maybe we could think outside the box here. Maybe we could use this as a neuropathic inhibitor. And the patient then began to experience almost significant immediate pain relief. So should we be looking at other factors, at gene-related peptide? Should we be looking at calcitonin? Should we be looking at other factors that are non-opioid and codependent? Should we be looking at mitogen-activated protein kinase? Should we sort of go really outside the box and try to find that holy grail that I indicated earlier, so we don't become so used to the norm, so codependent for the norm? It's just one of those ways that you sort of should be looking at things, I think, a little different than what we've done in the past. So this study had 15 patients. The participants had chronic neuropathic pain, mainly with CRPS, and the individuals were suffering for years with this condition. And after the administration of EFGR, the remarkable results were that people were able to eliminate their use of opioid medication. They were able to return to functional activity and eliminate a significant portion of their pain, which again asks us the question, should we even be administering opioids to our patients at all? Or if we do, should we give it to them in a limited time factor? Should we give it to them for 2 weeks, for 4 weeks, for 6 weeks? A recent colleague of all of ours just recently had back surgery, and he's a well-known neurosurgeon who's been very, very active in the community and very active in the world, actually. And this individual took Toradol for 2 days and Tylenol for 3 days, and that's all he took. And he had a lumbar fusion performed. So it's not always the route of taking an opioid, and even as a physician, he asked that his doctor not give him any opioid medication. So he did not even become sensitized or codependent on the medicine and relied on just the use of cold packs, hot packs, non-steroidal anti-inflammatories such as the Toradol was, and then some acetaminophen, and was able to do quite well. I'm going to just give you this little insight. I wanted to make sure we stayed on time, even though we had given me a little bit more time. I just wanted to remind everybody, I have a good friend of ours who spoke yesterday, Aaron Kolodny, and Aaron always sheds some light here. You've been carefully taught to make sure that you know all the angles. You've done this probably 1,000 times or more. It comes naturally because you guys understand and appreciate the physiology and anatomy of things. and you know that what you're doing is right. You've been trained by Alan Winnie and Brindenbaugh and everyone else in the room who's been instrumental in guiding us with our abilities. But nothing could possibly go wrong, right? Because I mean, we're just really good at what we do. But sometimes we have to be very careful because we can overstep our limits and our boundaries, and when we do so, the prescription of opioids can go a little bit beyond where we would like them to go. Remember, 72,000 people died last year, and in the whole Vietnam War, we only had 50,000 deaths, and that was over a 10-year period of time. So there's a lot going on that we can curtail ourselves and try to maybe police ourselves a little stronger, and maybe we should be doing that. But that was just a little insight. I want to say thank you very much for the opportunity of being here, and thank you very much for opening your minds to some alternative therapies. Thanks.